So I'm going to first introduce Ian Grant, who is a consultant plastic surgeon at Addenbrooke's Hospital and an honorary lecturer with Cambridge University, who is going to be kicking off the replantation talk with his talk, and he'll then introduce the other lecturers afterwards. So Ian, over to you. Thanks.
So I've got a pre-recorded talk, largely in case something went wrong, and we've had a puncture this morning. We've got somebody stuck in a lift, so it's probably a good thing. And Alex is very kindly going to tee that up and play that. If you have any questions, please put it through the question mechanism, and we'll take it from there. Thank you.
Thank you for giving up your weekend and time to attend the BFIRST BSSH webinar on replantation. I'd also like to thank the other members of the faculty and all of those that have helped to organise this talk. I'm going to give a whistle-stop tour, a very brief tour through replantation. I appreciate I might overlap with some of the stuff that will come up in later talks. And also, this is a gross simplification of a topic that we could talk about quite literally all day. I've got no particular disclosures. I'm going to talk about digital replantation, and I'm also going to talk about the replantation of hands and feet, or large segment replantation, which has a slightly different management and where timing issues, so need to get to theatre urgently, is a more important.
Alex, I've lost the sound on that. Is everyone else getting sound?
So the mechanism of injury, whether it's a sharp division or guillotine division, whether it's crush, whether it's avulsion, whether it's a combination of the crush and avulsion, and isolated injuries versus segmental injuries, where there may be an injury more proximal to the point of the amputation, which might have a higher importance than your attempts to reattach the finger or the limb, and might have an effect on its outcome. We're going to talk about how to transport the limb, or the digit, sorry, the diagnostic studies and X-ray. We'll talk about decision-making, which needs to be shared with the patient. We'll talk about planning surgery, the preparation of the stump and the amputate. We'll talk about a sequence of steps which will be reliable for digital replantation. We'll talk about the rehabilitation outcome and further surgery. In terms of the anatomy, this is not complicated stuff. There is an artery which runs on each side of the finger. There's some arborization across the finger on the palmar surface of the digit, immediately before and after each of the joints. As you run distally in the digit, the artery and the veins become much more diffuse. And if we look on the back of the hand, in the looser skin on the back of the hand, you've got veins which get bigger the more proximal you go, the more suitable for an anastomosis. We also need to be mindful of the fibroretinacular system and the position of the nerves, tendons, and joints. In terms of the mechanism of injury, the most common thing we see is a sharp division. Usually it's either a workman or someone working on their own property, doing what's called DIY, something like a circular saw. This saw took off these digits, and I think this is a case that I was involved in Leeds, and 3 of these digits were put back on again. There was a little bit of shortening, but this is more straightforward than, say, for example, a crush or an avulsion, which I'll come to. This really is a guillotine-like injury. It was carried out by a guillotine used to cut card. It was actually her husband that did this by inadvertently, I'd say. And these fingers were all put back on again. I don't know the long-term outcome. This was a case of Tony Burgess in Australia. Whilst on fellowship, I did see a sharp sword injury where a hand was taken off. Again, the fundamental principles were we got this patient to theatre pretty quickly. We shortened the bone a little bit. We fixed the bone first, then we did the extensor tendons, then the flexor tendons, then the vessels, and then the nerves. And the patient did pretty well. Needed a tenolysis at a later date, but actually recovered some intrinsic function and a hand that moved reasonably normally. But sadly, his life went downhill from there for one reason or another. Which crush injuries, this involves damage not just to the point of avulsion, but proximally and distally to it, and they're much more difficult to to put back on again, and this can affect your decision about whether to proceed. Classically, it's crushed in machinery or crushed by an object, and sometimes an avulsion can be combined with a crush. This is a limb that was a man was clambering out of a manhole, and the lorry came on and ripped his arm off, and a colleague thought it'd be a great idea to put it back on again, but there were lots more proximal injuries related to it, and the outcome was relatively poor. This is the most common thing we see, which is a finger that's been pulled off into machinery, or perhaps someone's fallen and the ring has caught on something, and you can see a tendon dangling from it. You can see sort of empty, hollow wrapping of skin. And in some of these patients, you can see this sign here, which is called the ribbon sign, where vessels form a sort of spiral. And these patients, if you are planning on replantation, you're going to have to think about vein grafts, nerve grafts, as well as shortening. So what's your order of preference? Would you like to have an avulsion or a crush or a sharp guillotine injury or multiple segmental injuries? And I think kind of we know the answer. A crush is pretty bad, an avulsion is pretty bad, sharp is good, and multiple injuries can be a really bad thing. So we'll move on from there. So how do you transport the digit? Well, you wrap the digit in damp gauze. You might want to clean it first, but you wrap it in damp gauze. You then put it in a bag, which you make sure is absolutely sealed. Then you put that bag on top of crushed ice with cold water or saline or whatever. So the temperature is pretty cold, but the finger itself is not in direct contact with the ice. And that should give you a greater chance of survival of the digit or the limb. And so there's data that suggests that if you keep the limb nice and cool, or the finger nice and cool, certainly for fingers, you can replant them 24 hours down the line. We've had all sorts of disasters where fingers have been put directly in ice, or they've been transferred in the patient's pocket and all sorts of things, but this is a very reliable thing. So what diagnostic studies you need? Well, just an X-ray really. Unless the patient's got systemic problems, unless it's bigger than just a finger that's come off, you just need an X-ray. Perhaps you might need some bloods to determine whether they're fit and appropriate for surgery. And in terms of decision making, you need to look at the condition of the stump and the condition of the amputated part. You need to look at the time the digit's been off the patient and how long they've been ischemic for, or warm ischemia. Have you got a theatre? Are there any other comorbidities? Has the patient got systemic illness? And how valuable it will be to the patient? Is this really what they want? There's circumstances. This is the Dawn Wall. This is Yosemite National Park in the States. This is a piece of rock that has never been climbed by humans until about 10 years ago, where Tommy Caldwell climbed it. Now, Tommy took off his index finger with a circular saw a couple of years before attempting this climb, but didn't have a replantation, because of worries. There may be other factors, but worries about stiffness, tenderness, pain, lack of stability, all those sort of things. So let's think about what our preference would be. Would it be an index finger of an adult, a child's thumb, an adult's thumb, multiple digits an adult, or an adult small finger perhaps? Well, I think we know the answer, which is a child's thumb. You'll do everything to get it back on. An adult's thumb, you do as much as you can. Multiple digits, you'll do everything you can, but not so much a small finger or an index finger. Sequence of events, well, tidy up both the amputate and the stump. Make sure someone experienced and capable is dealing with the amputate, not the most junior or most enthusiastic individual. Make sure they're comfortable, they've got an operating table to do it on, and the amputated part is held securely and safe. It's not bobbling around a bit. I make an incision on the lateral portion of each digit of the amputate and the stump if needs be. I shorten the bone using a saw, protecting the soft tissue with a glove with a hole in it placed over the bone. I pass 2 K wires and double-ended K wires that again get reversed, keeping them parallel rather than crossed. And I might use dental wire that you wind together to give stability and compression to the bone. Once I've done the bone, I'll then think about doing the extensor tendon. I'll flip the finger over and think about doing one artery and then hopefully another artery if all is going well. I'll do the flexor tendon, and then I'll flip the finger again over and do the veins on the back of the hand. Sometimes you need to roll an instrument down the back of the skin to reveal the presence of the veins and how full they are and which vein to go for. Sometimes there's a bit of an angle to find the best match. Clamps come off. Heparin is sprayed on arterial vasodilator onto the arterial vessels, and then everything picks up, hopefully. So I then do the nerve after I've let the tourniquet down, after the finger's vascularized, because I figure I probably found the nerve by that stage. I'm quite comfortable to prepare the nerve with some blood oozing everywhere, but I know other people say do the nerve immediately after the flexor tendons. So the same is true with if you're replanting something larger. This is another case from Melbourne, which is through the metacarpals, where we shortened the metacarpals, plated them. No, it's not from Melbourne, it's from Derby. This is someone else's slide, I do apologize. Metacarpals are shortened, they've obviously been plated, then the extensor tendons will be done, the hand will be flipped over, flexor tendons, artery, nerves, probably at this stage in this type of injury, then you turn the hand over and do the veins. So I'd like to thank you for paying attention, and there's more. In terms of the outcomes, you need to look at not just the survival of the digit, look at things that are relevant to the patient. So there is the TMI scoring system, which looks at range of movement, it looks at sensibility, whether it's painful, whether it tolerates cold, and then for larger larger replants, there's the Chen's criteria, which looks at whether the limb is actually useful to the patient, with grade 4, the worst outcome being an almost unusable function for the replanted limb, and most of those individuals probably want the limb removed. So looking at the outcomes, don't just look at the initial vascular success, but if you are, you should hope for between 80 and 95% success rates in your unit. It declines, however, if you look at those same figures 21 days down the line. You can look at range of movement, 2-point discrimination. So the range of movement is going to be about half or even less than what you had before. 2-point discrimination is going to be a whole grade lower, perhaps 10 to 12 millimeters 2-point discrimination. So sensibility reduces. You can look at DASH, you can look at MHQ. Some of these things create a lot of noise. In terms of factors that you can influence in terms of the outcome, a surgeon with more than 5 years experience has been shown to have a higher rate of success, 10 years, perhaps even higher. I wonder whether you come off the curve. So repair of multiple vessels seems to have a higher rate of success, 2 arteries, 2 veins. Units which do a lot of these things will do better. Surgeons that do a lot of these things will do better. I don't know whether if your surgeon does a lot of microsurgery, that's a factor. I think we also need to look at return to work, return to the same occupation, and specifically, do you do the same task in the same occupation? Loss of revenue. We're all in comfortable, established jobs, but a lot of our patients, particularly the ones that get injured, are in relatively tenuous employment. Will they keep their job? Will they keep their house, their relationships, and other factors? And also how often these patients have secondary procedures. I'd like to thank you all finally, and I hand over to my colleagues, probably for more detail and more clarity. Thank you.
Great, thanks, Ian. We've actually got 2 questions that have just come through, and they are sort of directly to you. So the first was, why do you do the extensor tendon first?
Okay, I can see 2 questions. Can you hear me? Regarding extensor first, simply because for the predominant number of replants for us that we see, we're fixing them through a dorsal approach. So if you fix the bone, the next thing to do is sort out the extensor tendon and then think about turning the hand over. I wouldn't necessarily do bone extensor vein for me. I would certainly do, bone extensor, turn the hand over, do the artery, do the flexor tendons, and then think about the vein when you've got perhaps a little bit more blood in the system. That's why the extensor first. And the next question is, if you can replant only one finger and need to choose between the index and little finger, which one would you replant and why? Well, okay, so this is a slightly existential question, because it's quite difficult, because if you're doing a toe transfer onto a hand which has only got a thumb, you might put the toe on the ring finger position, because that allows you to bring your hand across your palm a bit better. So I'm not really sure. It really depends upon looking on the x-ray, which is going to be the more fortuitous, where the bones match up a bit. And sometimes you'll replant one finger onto a different finger stump when the amputate is better condition and the stump is matches, but I don't really have an answer between whether I do the index and little. I think I'll probably do the index, to be honest. I know plenty of people who, well, I know several people who don't have a little finger and they seem to cope quite well. But then again, we know some people without index fingers that cope well. This is a difficult question.
I think had it been between the index and the ring finger, which is similar lengths, I've certainly seen a case where the ring finger was crushed. The index finger was a nice clean cut, but they put the index finger onto the ring finger stump to stop a sort of incompetent hand. The little finger and the ring finger, I don't know, that's
Tony, that's a very pertinent and intelligent answer, because when you do a toe to thumb a second toe transfer, the ring is one of the best places to put it.
Yeah.
So actually, a ring finger is a great place to put it. But as you know, the hand is in two subunits: index, middle, ring, and small.
Yeah. So
losing one from any one of those subunits isn't the end of the world. I don't want to be blasé about it. It'd be devastating if it was me, but I do know and have lived for a while with somebody who was missing part of an index finger, and he seemed to cope quite well.
Therese, yeah.
I was just going to add to that it's an extremely rare situation, which I've never actually come across. Because if you imagine it, to amputate the index and the little, usually everything in between goes as well, doesn't it? So I've never come across it. And yeah, I agree with everything else that was said. You're going to try and restore that ulnar side, aren't you? So for grip.
Yeah. Okay. So our next speaker unfortunately can't join us today, and that's Professor Sabapathy. He's certainly very well known. Hopefully, the majority of people may have heard of him. He trained in Madras in India, and in 1979, and then came and did a fellowship in plastic surgery in the UK, first of all in Stoke Mandeville, and then Cannesburn, both of which are still very big, renowned units in this country. Then went on to do a hand fellowship at the Kleiner Institute in Louisville in Kentucky in 1989, 1990, before then going back to Coimbatore to develop the upper limb unit at the Ganga Hospital, which has since then really emerged as one of the premier trauma, reconstructive and replantation centers in South Asia. And his interests very much are in hand surgery and microvascular reconstruction. So always gives fantastic talks. I'm very much looking forward to this one. And Alex, if you could play his talk, please.
Sure.
And we're currently up to 126 participants, which is fantastic.
I am happy to speak about digital replantation in the BSSH and BFIRST seminar. And thumb and digital digit replantations, they offer the rewarding results of microsurgery. And after amputation of the thumb or the finger, they form the best form of reconstruction. There is a difference between a digital replantation and a major replantation. Fundamentally, they are different because the amputated parts in the fingers do not have muscle. So in the process of replantation, systemic complications are not the real risk. So unlike a major replantation, speed is of secondary importance, but then high level of microsurgical skills and surgical time and logistics are very essential. Do they deserve doing single finger replants, digit replants, or are they worth doing? The answer is vehemently yes. As far as the thumb is concerned, it's worth doing at all levels because function will be enhanced whenever the thumb length is kept at a proper level. Even if it is an oblique amputation like this, when you replant it, it gives good results. And when you take the digits, if the amputations are distal to the proximal interphalangeal joints, you offer very good results because the insertion of the FDS is preserved in the proximal segment and good function is easily gained. In multi-digit replantations, we have 4 fingers lost. At least if you replant a single finger, it enhances the power, it enhances the pinch power and the span and the capacity of the hand as far as the function is concerned is increased. What's our experience? I personally feel to get established as a microsurgical unit, particularly in a developing country, I think now you need to do replants. They make news. So because of this, what would happen is you will get a lot of other trauma. Microsurgery survives by non-microsurgical work, and microsurgery gets non-microsurgical work. So digital replants, our patients are very happy with the outcome. Our patients do not suffer from cold intolerance, and it keeps the microsurgical skills of the unit high. And in this talk, we'll see the technical aspects which help us to get consistently good results. There's another benefit because of doing replantation, because it's the ability to salvage incomplete amputations with vascular compromise. In them, you get a better results because the flexor tendon may be intact, the nerves may be intact. So you get a better results if you salvage these conditions. And we do about 40 to 60 cases in this group itself. Now, how do we get them and what are the tips to get some good results? The first thing is if we have a tip replant or a distal replant, studying the part for examination itself is very important. If you have an assistant who doesn't keep it in a steady part, then it's very difficult for you to get the arteries and the veins in the amputated part. So how do you do that? One, it can be done if you have a good assistant, somebody could hold like this with 2 fingers, it's fine. Or many a time we ourselves do it with the patient of the ring finger, with the 3 fingers are used to do the dissection. And other 2 fingers are used to steady the amputated part. This is one. This comes with the experience. But if you're not as experienced like this, there's another way of doing it. This is a suture carrier that you find that whenever you use sutures, the bigger sutures. So there are a lot of perforators in this disc. We take a suture and take a suture through the nail so that it is held fast. And we find that it's much more easier for our assistants to support the finger when it is attached to a disc like this. This is a good idea to do that. And this is the way commonly we do the examination of the amputated part. The other way we have found is to take a broad forceps and keep the part between the 2 limbs of the forceps. And the assistant holds the 2 limbs today. So in this way, you find that means we are able to nicely take the part and then do it. This is a very good, this is another good way of studying the amputated part. And here you saw is after identifying a vein, we have not tagged that part. This is another good way of stabilizing the part. So that's just when the closer look, it appears like this. Another trick which I would like to tell you is when you have an amputated fingertip, before you start, you just squeeze the part. Quite often you'll find if they come up quickly, within about 5 to 6 hours, when you squeeze the amputated part, you will find some areas of spots which come up like this. So these are the areas where you have the veins. I think that's the part that you get. Always mark the veins and the arteries and nerves while in the process of identifying the vessels. Sometimes when we identify the vessels in the amputated part, it may be very obvious for you that they are there. But once the skeleton is fixed, once you fix it with the K-wire, you may have to really search for the ends. So always mark the veins, mark the arteries, mark the nerves. Debridement has to be good, but there is a difference in the debriding of this when you then combine to a normal wound. What we need to do is that you need to identify the vessels first, tag them with sutures, and then excise the contaminated tissue. The whole fingertip itself is small. If you debride just like that, taking away all the contaminants without identifying the vessels, there is a real risk that we may miss a few millimeters of the vessel. Loss of a few millimeters of vessel itself may pose a great problem when you do a replant. So first identify the vessels, clean them up, and then go ahead with the full confidence that they are safe, and then go ahead and debride. We can do significant bone shortening even in the distal replant. Normally we do about 0.5 centimeters on either side. Inadequate bone shortening is the commonest cause failure or is a mistake because it makes it too complicated an affair. If you shorten it adequately, we find that many times it avoids the need of a vein graft. You get good vessels for repair. In addition to that, you get good nerves because you could trim the nerves back to good quality ends before you do the repair. So both technically it makes it easy and functionally we get a better result. So identification of vessels, how many vessels you have to identify. As far as we are concerned, our dictum is you please do as much of vessels as possible, as many arteries as possible, as many veins as possible. But veins, we are at least to identify the 2 veins we are trying to identify. There is a correlation which exists between the number of veins repaired and success. There are some papers towards that. And as a rough line, what I have is that the cross-sectional area of the vein repaired must be at least be twice that of the artery. But if you ask me, is there any particular studies done or there's no study done, it's extremely difficult to do this. We find that when you have only one vein and artery, and if the vein is a good cross a big vein, that means almost always we succeed. So if it's a very thin vein, that means it could result in problem. So always my rough guide is that the cross-sectional area of the veins repaired must be at least twice as that of the artery. Now a question comes, you try to identify, some people say veins identification is very difficult. So one technique that has been advised is that you identify the veins after the arterial anastomosis. Is that the way we practice? Generally, I try not to do that because my feeling is that if you are not able to identify a vein when there is no bleeding under the microscope, a clear view, it perhaps will be more difficult to know afterwards after you repair the artery. I think this whole place becomes messy, a lot of blood, bleeding is there. So I try to identify before the veins, before we start the whole thing. But what's the problem in the veins? Most of the times people find it a problem because the veins are very superficial and people raise thick skin flaps and the vein goes with the flap. So the skin flap has to be very thin. And if you are doing a fingertip, at least you must have 5 millimeters of dorsal skin needs to be present for identification of dorsal veins. Otherwise, you need to go into the volar side. So here you find the dorsal veins, we have got about 5 to 6 centimeters of skin, so we are able to identify and repair the veins. When you repair the veins, it's not the thinness of the vessel wall is the problem. It's not the diameter. So even there at that level, the diameter is quite good. But then what makes it difficult to repair is the thinness of the vessel wall. That's the problem. So what we need to do is to keep flushing and then we flushing with fluid and we do it. And we need to use learn to use the zoom up and down during the beginning of your training. Then it makes it far easy. What is the solution that we use to flush? We use this. This was one what I got trained in Louisville. I'm using it. Do you find any evidence for this? There's no hardcore study for this, but then our teachers use this. I'm using it. I find it good. Our trainees are using this. What we do is 200 ml of saline plus 25 ml of xylocaine plus 2,000 units of heparin. This was what Dr. Sai used. This used to be called a Sai solution. We are also using the same. And it's important to use this. When you put in vessels inside the clamp, there may be some blood that is sticking inside beyond the place where you put the clamp. And what is really required, you need to have a very clear ends. And this is a solution that we use to flush the ends of the vessels. Now we come up to the arteries. They are more easily identifiable than the arteries. When you do a digital replant, there are some fingers, particularly the border digits, where one particular artery is a more dominant artery than another artery. That means this artery is a little bigger in size. So for the thumb, it's in the ulnar side distal artery. And the index, it's the ulnar side distal artery. And for the little finger, it's the radial side. So generally what is that is the inner part of the your finger. I think that's what the digital, that's where the digital arteries are bigger. So if I had to do a thumb replant or index finger replant or little finger replant, you would preferentially look for these side arteries. And in fact, the nature has kept it such a way that the contact surfaces, the nerves are thicker. So the radial side distal nerve of the index is the thickest distal nerve in the hand. So the ulnar side distal nerve and the radial side of the index finger, they are thick nerves. And whereas the arteries that are on the inner side, they are the dominant vessel. And that's what now you should preferentially understand. For the middle and ring, both are the same. If there's a gap between the vessel ends, a graft may be necessary. And when you do a digital replant, what are the best sources of grafts? The veins on the volar aspect of the wrist. I think these are the ones now which are good for the vessels. And how do we fix the bones? We use KOS. At Ganga, 99.5% of the times now we use KOS. And box type of sutures with stainless steel wires is another option. We find the KOS is quick, simple, and we just get going. So we use KOS and are not found any problems with that. One important thing, particularly for a beginner, if you're going to work in a developing country, we try to think of cost, but then one thing on which you cannot compromise are clamps. They need to be graduated. If they exhibit more pressure, if they're uncalibrated, that means every time you apply, you may damage the vessels, particularly digital arteries, digital veins, when you do a digital replantation. So what's the sequence we follow? We debride and we fix the bone. We repair the extensor tendon, flex the tendon, vein repair, nerve repair, and arterial repair, and then we do the clamp release. So when you do release the clamps, you do the artery first and release and do the rest, or you keep the artery to the last and then release the clamp. And it's our practice that we complete everything and then release the clamps, because in a digital replant, ischemia time is not a great issue. And it is easier to repair the tendons and nerves in a bloodless field. And you also could be, your repair could be much better in a bloodless field than in an area where you repair the artery, no veins have been repaired, so it's continuously keeps bleeding. So when we release the clamps, we use a warm saline liberally at the time of clamp release so that the spasm is to a great extent is relieved. So when you say use warm saline, it's not just at the site of the anastomosis, you just have to keep the whole of the hand warm. The patient needs to be warm, the patient's blood pressure needs to be good, he needs to be full and flushed. So the immediate satisfaction of the replant patient is that the survival of the replant, but then the long-term satisfaction, it depends on the quality of the bone fixation, tendon and the nerve repairs. You need to do them all primarily very well, because secondary surgeries in a replant is pretty difficult. So what are the problems that can happen? One of the problems that can happen is suturing the skin tightly. Don't suture the skin tightly, you leave with even with no sutures also, it's fine, it settles well. If you're worried about a raw area, what you could do is to put a small amount of thin graft in the raw area. So sometimes you can even replant without putting a KOR, particularly distal replants, where you can just repair the nail bed and then start repairing. This one way, this good advice. It is easy because when you repair the nail bed, and it gives a lot of some amount of pliability, it gives the movement it can have, than fixing with the KOM. In such distal levels, the arteries are down, deeper, and the veins are superficial. So you need to repair the artery first. We repair the artery first and still keep the 1 week clamp on, and then repair the vein and then let all of them go. So how do we do that? So what we do is we take in the sutures. We take in the sutures like this and get them in. And we find that whenever amputation is through the nail bed or through the sulcus, if you repair the nail bed nicely, what happens is that the bone comes into great approximation, and then you could do the repair. So that's what really happened. You repair the artery deep and then repair the vein and then let all the clamps open. At 18 months of follow-up, that's the picture that you get. Is highly impossible to identify which is the finger now which has been replanted. Our post-op schedule is that we put a big above elbow cast. It keeps them warm and they keep them in bed for 5 days. We discharge them about between 7 and 14 days. This is more to about the social status of the individual, where from they come, and the conditions at home. There's no hard and fast rule as to when we discharge. And we don't do any dressing change for 2 weeks if the replant gets good. We put in a cast and forget it, and then keep going. The anticoagulant regimen that we use is 2,000 to 5,000 units of heparin bolus at the time of clamp release. Is at the rate of 50 units per kg body weight. And we follow it up with 5,000 units of heparin and 500 ml of normal saline per day. Is there any evidence? I would say it's got a level 5 evidence. It's just what we practice and we use it. Have we used veins? The other place where we use have we used leeches? We personally have not great experience in leeches. Sometimes we do chemical leaching, in the sense we have to, if you don't wet veins or there's a venous compromise, you shave a little bit of the nail bed and then apply heparin in that area, or this solution which you could apply, so that you promote bleeding and decompression of the veins. At least you should do this for about 5 to 7 days. Physiotherapy you can start early. It depends on the bone fixation and the type of tendon repair you do. Doing digital replants, we think is difficult. It really doesn't. It's not really difficult, but it does require a high level of microsurgical skills. I personally think it's best acquired in the laboratory. A good infrastructure is essential, and a surgeon willing to change his schedules, keep doing until it become a routine. Start with single fingers in adults. People may say in single fingers it's not necessary. My argument is that if you don't do it in single fingers, you can't do multiple fingers. If you don't do a small fingertips, you can't do a thumb tip. If you don't do it in adults, you can't do it in children. So start with single fingers in adults. Then it will become a routine and you will get good results. In fact, one of the most rewarding results of microsurgery is doing digital replants. Thank you so much for this opportunity.
Great. Well, that was fantastic. As ever, whenever I listen to Professor Savapathy, I learn a whole load of new tips, tricks, and ideas. I thought I'd probably have heard something similar to that before, and there wasn't much more to learn. But as ever, he's taught me a lot more stuff. And it's just a great shame that he is not able to join us for the Q&A at this stage. So I don't know if there are, Professor Savapathy, he's not online, I'm afraid. He wasn't able to join us at this time, so that's why he has written, he's recorded the talks. So we could certainly ask him these questions. If we'll record the questions and see if he can get back to you with the answers of these. I don't know if anyone else on the panel feel they can answer any of these, or their views on one was about how do you shorten the bones, what size of clamps to use for digital arteries, and why xylocaine solution, not just lignocaine. I use lignocaine. I see it the same as xylocaine. I used it just the other day for such a case, so I think it does the same. Does anyone have any views on that in the panel?
I can touch on some of those points. In terms of shortening the bone, we use an oscillating saw. But what is tricky is to isolate the surrounding soft tissue so you don't damage them in the process. And what we have done, or I have done, is used if you get a glove with a very small hole in it, the bone can then poke through that glove. You know, you cut off with the glove, it can poke through, and that kind of protects the tissues of the stump when you use the saw through it. I suspect other people use nibblers and things like that, but I think I wouldn't get a clean cut with that. In terms of the size of the double clamp that he uses, I simply don't know what he uses. You tend to go for the smallest or the next smallest one. Someone asked about size of suture. We tend to use a 9/0, and then if needs be, go down to a 10/0. But some of our sutures, some of our micro instruments don't always cope with a 10/0, and certainly some of them don't cope with the 11/0, which I think you can just about cope with some instruments, but not always with ours. That probably answers some of those questions.
Just a quick point on the clamps for the distal arteries. If it's a distal fingertip or any fingertip, you don't really need a clamp on the distal artery until it's you've got a blood flow in it. So I often don't use a clamp on the distal part.
Okay. Right, Ian, shall I hand over to you to introduce the rest of our panel and the talks?
So we've got a few things that we'd like to do. We've got some polls and some quizzes. There are no prizes, I'm afraid. It'd be very difficult to get it out to you all. But I think we're going to go straight into a talk about a case, Miss Lang's talk, if that's okay, my colleague Therese Lang, on a case from 2020. And whilst I appreciate this isn't a hand, there are many of the same principles, and it was quite interesting for us because it was in the middle of the pandemic, or certainly in the middle of our phase of the pandemic.
I'll just unmute myself. Can everybody hear me? Yeah, all good to go? Great. So this case is of a little girl, age 5, taken by ambulance to Addenbrooke's mid-May. Let me just move that on. Sorry. Not working for some reason. There we are. Yeah, so yeah, as we said, middle of the pandemic, mid-May 2020, she was running behind a family member who was using a ride-on lawnmower. She slipped under the mower and injured both of her feet. Her left foot was amputated through the midfoot and her right great toe amputated through the MTP joint. The right great toe was destroyed and was not salvageable, but this is how we found her left foot. It was grossly contaminated with grass and debris, but the cut was sharp and it went obliquely through the mid part of the forefoot. There was a second deep laceration over the dorsum of the foot, and you can see that this almost completely encircled the base of the little toe. The x-rays showed more clearly the level of the injury extending through the navicular and cuboid bones. The cuneiforms were mostly intact. There were also fractures of the 2nd to 5th phalanges at the level of the distal laceration. And although it was grossly contaminated, this was a sharp amputation. The part was in reasonable condition. The patient was stable. And we decided that we probably could replant the foot and that it would probably give her a better outcome than a lower limb prosthesis. And so she was taken to theatre. A rapid COVID test was taken, and our anaesthetic colleagues set about putting in lines, catheters, while we inspected the part. We were 3 consultants working in 2 teams. We debrided as much of the debris as possible, removed the loose remaining navicular and part of the cuboid bones, and identified and tagged the vessels, nerves, tendons. We used K-wires to hold the bone. Initially, we placed 3, but later removed 1 as it wasn't adding much to stability, and we felt it might be an increased infection risk. And the vascular anastomosis was achieved with a 3-centimeter vein graft from the right ankle to the dorsalis pedis artery. We then repaired 2 veins, 1 on either side of the arterial repair. Both were dorsal, and all of our anastomosis we used 9-0 S&T. The ischemia time was just over 7 hours for this child. And so we decided to do this in 2 stages and took her back to theatre at 48 hours and repaired her nerves and tendons. We harvested sural nerve from the same ankle and placed 2 2.5-centimeter cable grafts to her plantar nerves. The tibialis anterior tendon was repaired, peroneus longus and brevis. The thick plantar fascia was also repaired. We didn't repair the long toe extensors as these were not primarily repairable. We terminalized her great toe on the other foot. So over the next few days, she was cared for in the high dependency unit, and about day 4, she started spiking temperatures. And at the same time, she developed a florid rash all over her body, which was quite worrying. Her urine output went down. And we took her back to theatre and inspected her wounds, looking for an infective source, but we didn't find anything. We also arranged for an MRI scan, and thankfully this didn't show any deep-seated infection either. Thankfully, with some changes to her antibiotic regime, her temperature settled over the next few days. Most of the replant survived. She did lose the little toe and also a thin bridge of skin across the dorsum of her foot, and this was debrided and grafted a few days later. She was discharged after 2 weeks. Her K-wires were removed at 6 weeks, and she was managed in a boot, and her dressings were changed as an outpatient, and she began to weight bear at 8 weeks. So just a few interesting points about this case. Obviously, it's a foot, which is quite unusual. Lower extremity replantation is controversial. Restoring blood supply is not enough to guarantee the successful replant. We know that the part needs to be in good condition. The replantation shouldn't pose a risk to the patient's life. The part needs to become functional with little or no pain in the long term. It needs to look acceptable. It needs to be an adequate length, and all of this needs to occur within an acceptable time frame to allow the patient to socially reintegrate and return to their normal life. And these parameters are more difficult, less common to be able to meet these conditions in the lower limb amputation than in an upper limb. We must acknowledge the LEAP study, which in this subgroup of patients reported no difference in outcomes between those who underwent limb salvage surgery or those who had amputations. And it also reported substantial numbers of poor outcomes in both groups. There are, however, a few reports of success in lower limb replantation, but the authors will always stress how each case was carefully selected, bearing in mind the factors that we know impact success in replantation. One of them, of course, is age. We know children are different. The microsurgery itself is definitely more challenging in anastomosing tiny vessels, but overall they do seem to do better than adults with replantation surgery. They have a higher potential for healing, specifically nerve regeneration, and also greater potential for adaptation to a new situation. There are plenty of reports in the literature of good outcomes in extremity replantation in children that demonstrate this. So the final point I'd like to highlight about this case was how we were working quite differently in our unit at the time of our presentation. Mid-May 2020 was the height of the first wave of COVID-19 in the UK. The country was in full lockdown. Our hospital, as many others, were dealing with a large influx of quite sick COVID-positive patients. Surgery was restricted essentially to life and limb saving operations only. And there were significant challenges to operating at that time. Delays getting patients to theatre, delays waiting for test results, restrictions to movement in and out of the theatre, having to wear the cumbersome protective equipment, which did not allow for use of a microscope. It was difficult to communicate with colleagues while wearing this equipment. There were lots of questions at the time. Simple ones, could we use a dermatome safely? And then more serious ones, what was the impact of a long general anesthesia on a patient who might catch COVID in the perioperative period? And what was the risk to children? We know a lot of these answers now, we didn't know them then. There were some positive changes which we made to the way that we worked during this time. Our trainees had been redeployed to work in A&E and on the COVID wards, and so we had to reorganize ourselves with more consultants on the ground for emergency care than we would have had under normal circumstances. And so when this girl arrived, she was attended in A&E by not just one, but by 3 hand consultants, 2 consultant anesthetists, the vascular consultant, an orthopedic consultant. The movement to theatre was swift, the team discussions, the case setup, the whole operation itself felt very well coordinated, relaxed and almost rehearsed. And that positive support, the team atmosphere, the level of expertise we felt was hugely helpful. And we now have a desire and an informal arrangement, as thankfully these cases are rare, that for these type of cases, we will try to use a similar multi-consultant team approach. So getting back to our child, she is now 8. She's doing well in very many ways. And these images show the cosmetic outcome, which is not perfect, but she is happy with it. She delights in painting her nails a different color every time she comes to see us in clinic. She has a pretty good range of movement. She does lack some coronal plane movement, but her ability to go up and down her toes means she can still do her gymnastics, which she does and she loves. She has some shortening of her Achilles tendon. You can see on the x-rays that there's a difference between the calcaneal pitch, which is normal, 30 degrees on the right, but almost 0 on the left. And from this, we're suspecting she might benefit from Achilles tendon lengthening at some point in the future. Her x-ray shows, however, that she is still growing in comparison, and the foot is growing in comparison to the other side. Growth plates are all wide open, apart from those which were directly injured by of the left phalanges. And finally, I have a short video which hopefully will play. You can see there is a degree of an adduction deformity and overpronation, but she doesn't report any functional problems. She does her gymnastics, can go right up on her toes. As I said, she rides a pony and stretches her Achilles that way. She has full sensation everywhere on the foot. She had some hypersensitivity, but it's not uncomfortable, she says, rather more ticklish than the other side. She also runs. Unfortunately, I don't have a video of this, but she tells me she ran 2 miles in her cross country a couple of weeks ago and was really pleased to come 11th out of 15 of her classmates. She's a very confident, sociable girl, and that really has helped with her recovery. So just to summarize, replantation is difficult at any point, but during a pandemic, it is particularly difficult, and we were lucky to have an experienced team, which was vital for us to overcome those COVID-related difficulties. And of course, the children are amazing. Their abilities to heal, their general abilities to physically recover from injury, and also their psychological abilities to deal with trauma often definitely make it easier for them to make an excellent recovery. And I'll just like to take this point to acknowledge the many people who are involved in the care of this child. Too many to mention. Just want to see if there's any questions on that.
Therese, there's a question from Manuela about outcomes in different levels of digital replantation. And it's a fantastic outcome for the foot we put back on. You might be able to answer that.
You're muted, Therese. You're muted.
Sorry. So yeah, my discussion will depend on a lot of things, but in terms of that, I will always, for digits, I would probably say to people, you will get approximately a 50% range of movement in this digit. You will get protective sensation. Most of them do, to be honest, and then it's anything beyond that is a benefit. In the ideal world, they will not have a painful, cold extremity, and that's the worst thing that can happen. You know, that's the time when they will ask you to have it removed, rather than a stiff one with less than perfect sensation. With the lower limb, you know, the rates of sensory recovery are going to be lesser, so you will obviously counsel them on that fact. And yeah, there'll be lots of other factors that will come into whether or not you're going to proceed and do this, rather aside from the functional outcome. I present in Ireland, we reviewed 30 of these cases, and I've published it, and interviewed every one of them that was available for interview. And it was very surprising that despite a poor sensory recovery and motor function in a lot of patients, they were very satisfied with their replant, and we're happier as you know. It's obviously difficult to say these things in retrospect, but we're happier to have their limb rather than not have it. The two failures we had in that series were lower limbs in adults.
Can I clarify one point? Is that okay?
Yeah.
Yeah, so with digital replantation, if it's on ice, you could even leave it 24 hours. The data suggests that there's no big difference between less than 12 hours, for example, and longer than 12 hours, as long as it's on ice. And there's some less strong data that says you could even leave it 24 hours. But with a large segment, a hand or a foot or an arm, you've got 6 hours or 6 or 7 hours, or that sort of period. And although the success rate can be just as high if you're outside that window of opportunity, the rate of keeping the limb and the secondary procedures and necrosis just start to rise exponentially when the time gets beyond that. And I know there's not huge data on that. I see Rod Dunn is on the audience delegates. I think they had a bilateral upper limb replantation. And from recollection, he put that on, he and the surgeons at Salisbury put that on pretty quickly within hours of the night. And this girl, she had her warm ischemia was only about, was it seven hours, Therese, is that right?
This girl was 7 hours, and it was so distal, as you said. You know, it makes it's how much muscle is in that part is really the question you need to ask yourself in terms of ischemia time, because that's what it affects.
I come in there because Raja isn't here. I had the benefit of doing my fellowship with Raja in Coimbatore, which was incredible, as many others have done who are listening on the committee. And certainly Raja is very clear about longitudinal specialization. If there's muscle in the amputate, then largely it'll be stripped out, because even with revascularization, that muscle often does badly and becomes fibrotic. So that was one of his teaching points on the larger replants, for exactly the reasons you mentioned, Ian.
So Therese, I've got a question, but now that you've done a foot replant, do you see there as an age limit, or what with the similar injury? Because this was a contaminated, dirty, multi-level wound. Okay, one was partial, one was complete. But where is your limit now, do you think, on when you would replant a foot?
I don't think you can give an answer to that until the patient is there in front of you and everything, and you put all the factors together and you make a decision with, you know, the parents, etc. There were lots of good things going for this child. It wasn't
not a child.
Sorry, not a child. So there's lots of good things going for this child. It was distal. It was beyond the talus. You know, she's still going to have ankle movement. Although it was multi-level, the vascular anastomosis wasn't multi-level. The nerve wasn't multi-level. Do you know what I mean? So there were positive, and although it was contaminated, it was actually a very clean, sharp cut. So it wasn't, not an avulsion injury. We caught it, even though it was 7 hours ischemia time, there wasn't a whole lot of muscle in it, just her small muscle. So, all of those things, and it being a 5-year-old, you're going to give it every chance it could get. Would I have an age cut off? Not really with those positive things. I think that, definitely not in a child or a young person. Let's put it that way.
Congratulations. Right, are we moving on, Ian, or are you?
So what would you like to do now? We could do the polls, or we could do Patrick Gillespie.
In your polls, Ian, do you have questions that we need to wait for feedback for, or I haven't actually seen how many questions there are.
Not too many. So Patrick, do you want to be at the end or before? Should we do the questions now?
Yeah.
The polls and questions now, and then round up with Patrick, and then we'll do a sort of summary at the end, if that's okay. We'll see if people tail off. So here we go. Do I need to read this out?
Why not? We can see it, but just in case someone's got.
Right. So, do you have access to microsurgery, micro instruments, or equivalent? And so, I hope everyone can see this. It looks like 4/5, 80% of those that are signing up do, which is incredible. So, how do I get to the next one?
Alex will have to forward it, I think. Alex,
I've got it.
Yeah.
Do you have access to an out-of-hours emergency operating theatre to put an amputated digit back? I know we've spoken about how you could leave it till the next morning. Okay, so whilst many units have microsurgical access, they may not have access outside of hours. And certainly we struggle at times because we're a liver transplant centre, and they do tend to monopolize the theatre a little bit. Well, that's very interesting. There's more. Okay.
So we can't see the results. So what was the result on that?
The result is, share results. Here we go. I'm learning it.
Oh, there we go. Yeah.
Yeah, I'm learning something every day. So 70% of people do have out of hours access.
Great. Okay.
All right. So Alex, can you get the next one up? Because I don't seem to be able to. Stop sharing. Here we go. If you had hello. Have you got that?
Yeah.
You had a clean, sharp division of your own left, non-preferred hand, index finger, distal to the PIP joint, and you're off the replant, would you say yes or no? Okay, so the numbers are coming in. And this is an audience of surgeons and interested participants. And even though we should be, I'm going to end this poll now, share the results. How interesting. 25% of us would say no. I'm not going.
Ian, I wonder if that was a zone 2 amputation proximal to PIP, whether the answer would be the same.
Yeah, that's a good point. It'd also be interesting to see where people are located. People in colder climates may be less preferable of having an index finger put back on, and those from more Asian countries where obviously it's deemed that they should have all the digits present. It'd be interesting, actually. One thing I didn't say at the beginning is for people just to put in the chat where they've dialed in from. It's quite enlightening to see where people have listening from.
I think your comment about cold intolerance really is a big thing. For me, to have a finger that was uncomfortable in cold weather would be quite tough, actually.
Yeah.
But yeah, that's really helpful. We'll stop sharing that. And now we're going to some questions. There's 6 questions. So how can you need to say which list the following mechanism of injury causing an amputation in order of badness? Which is the worst? Can you do, is that working out okay? Can you see that? Is that coming up on everyone's screen?
Yeah, I can see it, but as a panelist, I can't contribute. So
it's all coming up now.
Yeah.
Are you saying which one is worst first? So
Yeah.
A should be the worst.
Worst, second worst, third worst, least worst. Thank you to Malika for tidying that up. That's great. Yeah, so everyone, I think we've got enough there. I think we've all got this, that, you know, segmental injuries are pretty bad, blast injuries are pretty bad, ring avulsions are next bad. And
can you show the results of those, or are they not shareable? That
oh, got it.
There we go. Yeah, thanks. Yeah.
Okay, moving on. How would you advise an avulsed digit is to be, yeah, this is easy stuff, isn't it? Okay, so I think we've all got that. Sealed bag, moist gauze on ice or iced water, but you want to make sure that it doesn't actually get a cold injury from the ice itself. Are there any reasons why you would not replant an amputated digit?
And they can choose more than one option here, can't they?
Yeah, I guess so. More than one. Yeah. The question on this I struggle with is acute psychosis, because psychosis is a reversible, you know, an acute psychotic episode can be reversed as opposed to a chronic psychiatric illness. I'm not sure where that leaves us, whether you would say, you know, because they're acutely psychotic, it will be difficult to give them a good outcome, or whether you put the finger back on and then deal with the psychosis. Systemic illness such as diabetes isn't a total contraindication. It depends upon the severity of it. And prolonged warm ischemia would, I suspect, would be relatively strong.
Can we see the results now?
Yeah, it's coming up.
There we go.
There you go. Yeah, I mean, it shows that we're all mindful of the other injuries that could be associated with it if it's a polytrauma patient. Okay, working through these questions now. Here we go, almost there. So this is your investigation for an isolated finger avulsion, let's say. No one wants to find out about their health insurance. Oh no, somebody does, and maybe there is some mileage in that, you know. But okay. No one wants an angiogram, which is very reassuring. And then there's more. Right. So this is the order in which you would do things. Which would you do first? I'm not going to comment on this. I'm just going to share it with all of you. We've got quite a few people chipped in now. About half of maybe a third of the participants. Actually, hold on, there's more coming. Right. I'm going to end that poll now. Share the results. Yeah, so I think everyone's got the gist of this, that you debride and tidy up, you shorten the bone, and go from there. Extensor tendon, flexor tendon, and then you can decide when you do the nerve and the artery. And then final question. I can't remember what it was. This is about outcomes and what you tell the patient. More than one answer can be correct.
Oh, it's a single choice actually on the question, but I might be.
Oh God, it is, yeah. That's a typing error.
Well, I suppose it's which is the most likely.
Well, let's see what people gets the most popular comment. I might have spelled feel wrongly. I'm not sure actually. It's like dyslexia then. Okay. I think it's very brave. The four contributors who say it's as good as new. Well, that's very brave. But I suppose a very distal tip implant replant could be almost as good as new. And some of those that Professor Sabapathy showed looked fantastic. Yeah, it's going to be a bit stiffer. You'll have to have some rehabilitation, and you have a very high likelihood of secondary surgery. I think that's all fair. So that's the end of the questions and polls.
You've just muted yourself, Ian, if you're introducing Patrick.
Oh, so Patrick Gillespie has been a consultant plastic surgeon since about 2005, 6. And he's a brilliant microsurgeon, a fantastic hand surgeon. He's currently working in Exeter, much to our loss.
Thank you, Ian. That's very kind. And I had a wonderful time working in Cambridge. I also had a wonderful time in fellowships, both in Chelmsford and in Coimbatore, as I mentioned. And a big point to make is get well trained, see experienced people do it and learn from them, as we all saw from Raj's talk today. So I'm going to try and share my screen now for talk. Not everything goes well, and I've decided to show a case that didn't go well in the end, briefly. We do successful replants down next year. We've had a bit of a flurry. Hope it's not related to my arrival, but I'm going to try and share my screen now. So bear with me for a second. I hope you're able to see that. Can somebody confirm if you can't see that? Ladies and gentlemen, good afternoon. And first of all, I'd like to thank BSSH and BFIRST for the opportunity, the fantastic opportunity to speak to you all today. I would like to give a brief presentation on another replantation case, building on the things we're going to hear today, the possible and the impossible. This is a multi-finger replantation case that took place in Exeter this year. I'm one of the consultant surgeons there, having been a consultant in Cambridge for over 10 years with my colleagues. And this was a healthy man in good physical condition and systemically well, who unfortunately amputated 3 digits in a 5-digit injury with a circular saw. He was 71 years old, which is important, had injury at 3 o'clock in the afternoon. He was right-handed and a carpenter, and he was medically fit other than his diabetes. This is the injury, as you can see here, with the 3 digits. And actually, importantly, we had to examine his other hand because he had a very short index finger compared to his ring finger, which was confusing to start with until we looked to the contralateral hand. Factors in favor of replantation were that he was systemically good for his age, despite being 71. There were good veins visible in the dorsal aspect of the hand and the fingers. It was a multi-digit injury. The amputate had been treated correctly, cooling and so on as per standard protocols. He was continuing to work, and the concept that if we attempt a 3-finger replant, we may succeed in 3 or 2 or 1 or possibly nil, but if we save some digits, there's more left to work with going forwards. Against it is the fact he was 71, he did have type 2 diabetes, and of course the risks of surgery. After consultation with 2 hand consultants, he went to theatre 5 hours after injury. The surgery was a technical success. The fingers were replanted using standard techniques and were well perfused at the end of surgery. We actually used plating, and with 2 consultant surgeons, we had a system in place where each digit was pre-plated, and therefore when the digit came to be reattached to start the soft tissue surgery, all that was required was 2 screws to be put in place, and then the soft tissue surgery could be started. And this was to minimize the warm ischemia time for the digits over what was overall a long operation. What technical tips do we learn from this and from similar operations in the past? We use a cool bath with cool saline with ice cubes sealed in sterile gloves so that the amputates that aren't being reattached at that stage can be kept cool in preparation. So they can go off to a separate bench, be pre-plated, be pre-drilled on the receiving side of the digit, and then when the surgeon at the hand is ready, they can come and be attached without having lengthy warm ischemia time. We had 2 senior surgeons. We thought very hard about the sequencing in terms of the bony work and so on, the soft tissue work. I think that depends on your own personal preferences. We took regular mini breaks individually, but the operation flowed continually as there were 2 of us. And I'd concentrate on the big picture. What are we trying to achieve here? And we were trying to achieve successful reattachment of functional tissue on this gentleman's working hand. And the learning point from this was ultimately it was all about the veins. What did we find? Well, unfortunately, at operation, despite having great arteries, he had poor veins, particularly the more distally in the fingers we examined. They were distally branching, they were small, they were relatively poor quality. We required some vein grafts actually to achieve flow. It was technically challenging. However, we did achieve good flow on the table for all 3 digits, and we did decide to use some systemic agents, heparin and aspirin, for thromboprophylaxis. Subsequently, it became more difficult. The flow was not maintained from 24 hours post-op. There was clearly venous congestion, and the leeches were then used. He was re-explored on table, but there was no microvascular improvement that could be achieved despite a re-examination with the microscope, etc. So leeches were continued for quite a long period of time. I won't dwell on the details. He did require transfusion, and that's well supported in the literature, both in Taiwan and the USA. There's quite reasonable, extensive literature on tip replant without vein repairs, and this is tip replant, not more proximal digits, but quite high success rates requiring external bleeding through physical methods or leeches for 5 to 10 days in Taiwan, and requiring transfusion. In one reported case, a patient required 9 units, or a patient required several units. To cut a long story short, unfortunately, despite all our best efforts, there was microvascular thrombosis leading to slow and terminally inevitable decline and death of his fingers, and they were largely removed. And that was not our intention at the time of the surgery, but his hand was salvaged, and he is functioning well and considering other options at the moment. So the lessons learned, every element of the operation is critical. What may be technically possible at the start of the operation, it may become clear that actually there are elements you can't appreciate until you explore the hand that make the operation even more challenging. And that was the case in this patient with his poor dorsal venous supply and the amputates, so venous drainage. Would I do the same thing again if presented with a 3-digit amputation in a patient? I would consider it. I would undertake a full consent process with the patient to make them aware of all the possible options. And it certainly, I would consider performing it for the same reasons as we considered it in this case. Thank you very much. So a few more things to add. Our regime with heparin is very similar to what Raja Sabpathi uses in India. I'll just, have I got rid of the share? Just, I hope so. We tried, can you hear me?
We can. You're still on the share screen. You just, but it's all right. We can see a little version of you. So
okay, I'm only a little. Having some technical problems getting rid of the share. Apologies.
I wouldn't worry. It's fine like that. Maybe Alex can do that in the background if he's still there.
The heparin we use very similar program to Raj Sabpathi, and we also use mechanical bleeding as well. And there was just a slow incremental death, and the arteries kept flowing for quite a long time, and the finger just sequentially slowed and died. And we had them in theatre. We were washing and cleaning them. We explored them, and we tried very hard, and we could not salvage any of the 3 fingers. Sadly, portions of them survived, but they were shortened or removed in their entirety. So sometimes it's very difficult, and sometimes it's not successful. Reviewing the literature, I saw some of the questions coming up talking about giving 20,000 units of heparin over 24 hours. I reviewed the literature both at the time and subsequently, and it's not absolutely clear what the best regimen is, or even if there is a best regimen. There's evidence suggesting that 10 or 12,000 units is more than continually, or even 20,000 continually is better than boluses, but then there are papers showing that isn't the case. So the evidence is very mixed, and you have to balance it against obviously the risks. And him, a 71-year-old, his HB dropped briefly overnight to 6.9. Generally, that was corrected quite quickly. It may have been delusional. Generally, we kept him between sort of 7.7 and sort of 8.5, 8.7. So quite significant systemic factors. And one of my first cases as a fellow in Chelmsford was actually a pulp replant in a young lady, and she was leached, and she dropped her HB down to about 7 from a little finger pulp. So you can lose a lot of blood from a very small area if you're leaching for 5 to 10 days. And that's about it. Nothing else to say. Very happy to answer questions.
I think you answered one already as we went along. One was, why do you use the plates, not the wires? But as you said, the person with the amputated parts was putting the plates on. Yeah. So it was half of it was already done. I presume that's the reason.
And I use wires regularly as well. And actually, interestingly, up at BAPRAS last couple of days, Carlos was there from Derby, and he's now talking about using screws, Accutrack or similar, different versions of, for replants as well as for fractures. So there's a whole host of ways of doing it. I would normally use K-wires probably, but in this case with 2 of us, and we had the time and the skill, the plates seemed to make sense because you brought the digit across, 2 screws that you'd pre-measured, bang, bang, the finger was attached, and then you put it in the soft tissue.
Yeah, I can see that does speed things up. And actually having a 2-team approach where people can prepare everything on the amputated part of the artery, the nerve, everything, certainly will speed things up as well. And the next question was, oh, it's just disappeared. I think the question was there a second ago, but I think
I think I've just answered that actually. So sorry about that.
Okay.
Can I touch on the two-team approach?
Yes.
So Miss Lang's had to nip out to go and see a genuinely sick child. I think when you have people that you fully trust and you fully feel comfortable with, then a replant can actually be a really positive, not particularly stressy, progressive thing. Difficulty comes if you have a two-team approach and you're doing one bit of it, the amputate, for example, or the stump, but you're also trying to supervise and keep an eye upon what's happening to the amputate, and that can be really difficult. And on the rare occasion I've been in that situation where I've not been totally comfortable, I've done both sides. So I don't think a two-team approach in itself is an obligate absolute, because you do really have to be comfortable what you're doing. And sometimes it's just people are very good-natured, but they're just not used to where to make the incision, how thin. Professor Sabapathy showed how thin to lift up that skin to show the veins. And it's very easy to inadvertently squish things and squash things and make things very difficult. I've certainly had lots of people putting stitches in the amputate, which is to mark things which are patently obvious. So with that child, another point to make with the child is that when they were going to throw that foot away, the initial phone call came through that they're preparing to do a through-foot amputation, and the A&E consultant said, do you want to have a look at the foot? And I can't remember if it was myself or Miss Lang said, well, does it look like a foot? And generally a digit that looks like, or a limb that looks like what it originally was, it's likely to be more replantable than something that looks more less easy to recognize. Thank you.
Great. Well, I think we'll round it up there. We've had we went up to just over 140 participants. We've stayed with very good retention at 133 throughout. So everyone's obviously been engaged, found it very interesting. I thought they were excellent talks. I'd like to just thank, I will let Ian take over at the very end, but I'll just thank all the people for their relevant talks. I just want to say that there will be some more talks coming up. I believe the next one is, in fact, Jonathan Jones is just on the panel. I don't know if you want to dial in, Jonathan, and reveal yourself, who is the chairman. He's going to be giving a talk in January. I'm just going to quickly advertise a talk for next Saturday. It is a plastics one for BFIRST. It's by a consultant in Norwich called Richard Hayward, who's talking on the serratus anterior flap, how he raises it, what he uses it for. He's the only surgeon I know who uses it with any frequency normally for long defects of the lower limb. I'm talking generally on flaps around the thoracodorsal axis. So that's going to be at 2 o'clock next Saturday. And if Jonathan is going to reveal himself, he's still on mute and not there. He's not coming.
Jonathan. Can you hear me?
Yes, go for it, Jonathan.
Sorry, because I'm kind of just partly looking at different other screens and things, but no, look, great webinar, really enjoyed it. The next webinar is in January, and it's going to be the part 2 of the wrist injuries webinar, which is on perilunate, injuries, carpal fractures, and dislocations of wrists. So please do join us for that, and do have a look at the wrist part 1 that we did last year, because you can do that as a bit of a reminder of where we were at. So thanks very much for all your hard work on that, and carry on with your summarization.
So I believe that'll be on the 28th of January, is what I saw it penciled in at. We'll confirm that close to the time. That's wrist injury part 2. These talks will be available on the BSSH YouTube channel. And I'd just like to thank everyone. If Ian I don't know if Ian wants to say anything more, but otherwise very great talks. And I really enjoyed it. Hopefully you'll dial in for some of the more talks in the future. Ian, anything more you wanted to say?
No, I mean, there are a few things we haven't touched on. We haven't talked about the anesthesia. We haven't talked about regional blocks. We haven't really touched upon time off work. And I think those are really important issues. For a limb replant, it's 12 months minimum. We haven't talked about whether people go back to exactly the same type of jobs, but we're dealing with such a different thing. But those are the sort of things we probably ought to think about, and the likelihood of needing a TENA lysis. My experience has been that everyone who has a replant ends up having a TENA lysis at some stage. We haven't talked about the psychology of it, but as I said at the start, we could talk about this topic like all day, because it does, when it happens, it takes up so many resources, and it's such a huge issue. So I think in summary, I'd just like to thank everyone who's chipped in and helped and made this work, and just all of you for dialing in on a Sunday, on a Saturday, when you've probably got many other things to do. And thank you very much.
Great, thank you all. Take care. See you again. Bye.